Kaya, you still there?
Hello.
Hello. Are you able? Are you able to bring up the coding animation?
Yeah, bear with me 2
Um,
seconds.
my computer is. Oh, maybe it might work actually. Give me a second. Let me see if I
Okay.
can do it. If I can do it, that'd be great. If not, um, there we go. Okay. Ah, finally.
Perfect.
This animation will give an overview of clinical coding in the NHS. Essentially, clinical coding is the way an NHS organisation records information on what care is given to their patients. It is the translation of the patient record into coded data. It is usually done after the patient has been discharged, and there are strict deadlines that need to be adhered to for data submission. So how does clinical coding work? A patient's hospital stay, from the point of admission to discharge, is called a spell. During their stay, a patient may be under the care of different consultants. This may be due to a change in shift, ward, or speciality. The time period under each consultant is called a finished consultant episode, FCE, or episode of care. So a spell can be made up of a single or multiple FCEs. Clinical coders code diagnoses, comorbidities, complications, and any procedures undertaken for each FCE. So how do we get from treatment to coded episode? All care delivered during a patient episode is documented in the patient notes. Once the episode is complete, the notes are sent to clinical coding, where trained clinical coders carefully read through the notes and allocate the appropriate alphanumeric codes. For diagnoses, they use the International Classification of Diseases 10th edition, ICD-10, which comprises over 16,000 codes. And for procedures and operations, the OPCS Classification of Interventions and Procedures version 4.9, which has over 4,000 codes for procedures and operations. The codes are entered in computer software which determines the Healthcare Resource Group, HRG. Most, but not all HRGs have an associated tariff. An example of this: clinical coders are like detectives, investigating all aspects of their journey from start to finish. You begin by reviewing the documentation, physical and/or digital, for the stay. For example, an elderly woman who had a hip operation 2 days ago. From her medical notes, you find out the main condition being treated, any relevant comorbidities, and the procedure performed. Then, utilising the ICD-10 and OPCS procedure classifications, you find and assign the special alphanumeric codes and record these into the organisation's patient administration system. This coded data can be understood throughout the NHS and beyond, and used to plan for future patient care. What are healthcare resource groups, or HRGs? A healthcare resource group, HRG, is a grouping of diagnoses and/or procedures which are similar in terms of care delivered and the resource used. In order to reflect the complexity of care delivered, HRGs capture main condition treated, investigated, procedures, investigations performed, comorbidities, complications, age, length of stay. Healthcare resource groups offer organisations the ability to understand their activity in terms of the type of patients they care for and the treatments they undertake. Why is clinical coding so important? Clinical coding provides the information that underpins almost all the data flows within the hospital. It can be used for clinical governance, quality improvement, epidemiology, benchmarking, commissioning, financial flows. The challenge: coders are only able to use information that has been documented in the clinical notes. Incomplete or unclear documentation has been repeatedly shown as a weak link in the data quality chain. Now we know how important accurate clinical coding is to NHS organisations. Here are some top coding tips. Clear. Write clearly and legibly, type if possible. Use appropriate language. Check with your organisation, as some have agreements to accept certain terms. Complete. Ensure all diagnoses and procedures are recorded in detail. Document all relevant comorbidities. Understandable. Abbreviations and shorthand cannot be coded. Coders are not allowed to interpret investigations or numbers. Accessible. Make sure the coding team know where key information is recorded.
Okay. This and right. Let me stop sharing again now. Okay, so the essence of it is that coding is really important. It still plays a big role in determining how much you get paid, but not directly. It's more indirect way of doing it, but it actually has a bigger role in other metrics. Still playing in the background. Has a bigger role in other metrics such as mortality data in terms of it's what feeds into your model hospital or model health system data, and also helps with kind of things like epidemiology and public health studies, and this population health management is all determined by your coding, and it feeds into the PLIC system, your costing systems. So again, it's really important to get it accurate. Some of the kind of pitfalls that you'll have within your organizations. So first of all, it's just writing. It depends on what kind of systems you use, whether you have paper-based notes or whether you have kind of electronic systems. One of the issues that we're having, so at my trust, is that we are in a transition stage where we've got most of our documentation is still paper-based, but we have a lot of we're developing an EPR. So there's stuff in one system, so either in the paper, but may not be in the other one. And then the coronavirus pandemic has dramatically changed how we code. So we were coding from our entire patient record, so from the main notes. But as coders went home and started coding from home, we were kind of completely reliant on electronic records. And that worked initially because of COVID. We were doing a lot more stuff on the electronic system. But as we're not doing so much on the electronic system, and we're going back to a lot of our paper notes, but we're still coding from our electronic systems. So it's a kind of making sure that the coders know where the best places to look for where the information is. So I don't know what have they got at LTH and Blackpool. Have they got and other places that you guys are? You've got electronic, have you got paper or a mix?
In my case, I don't really know what they have because I just received
You get the report. Yeah.
I just want to know how the data is there. So
yeah. Okay. So if you've got electronic mostly, is it all in a single EPR system? Because the other issue is that one of the issues that we have is that we have multiple systems, so we don't have a single EPR yet. It's all being linked in, and so we found that some of our therapy data, for example. So whilst you might have a single electronic record, does that mean that all the information gets fed into that system? So our occupational therapists and physios and stuff like that was on a different system, which the coders weren't looking at. So when we had a consultancy firm come in and do some work before the pandemic, pre-pandemic, and they identified what would have been at that time £10 million worth of coding errors, mainly from just not putting in things like therapy data, not putting in data of occupational therapy contacts, of physio contacts. And so it's important to know where the data is being stored. Sometimes cardiology or gastroenterology in the endoscopy units have different internal systems which need to feed into the main system. So you need to kind of make sure that the coders have access to that. There are other subtle things. So the biggest issue that we have is abbreviations. We all clinicians, we tend to use abbreviations a lot because it's just shorthand, but they can't be coded. So almost no abbreviations can be coded, and numbers, so up arrow K can't be coded for high potassium, even though it's quite clear what it means to us. It can't be coded in that way. So a lot of places are introducing what's called SNOMED terminology. So it's more of a medical. So coding uses ICD-10 and OPCS are much more coded classification systems rather than which have alphanumeric codes. SNOMED is a medical clinical terminology system, but it can be mapped easier. But it means that you can type in to your electronic record, high potassium, and it would come up as hyperkalemia, or you can type in TOF or any other abbreviation, and you can choose then which version, what the abbreviation means. So that's a lot of systems are coming up with that, and it's just now implementing it and then tracking it across, and that is what's going to happen. So SNOMED has been determined as the coding or the clinical terminology system that we'll be using in the future, but across the board. So that's not just in acute hospitals, but in mental health and in the community systems. But other issues that you can find in coding is to do with how people are recorded. So there's a difference between if you're an inpatient, a ward attender, a day case. They all have different classifications, have different coding requirements. So one of the biggest issues another issue that we've had in the past is that not all of our data is captured. We had patients being attending wards, for plastic surgery reviews or community reviews, where there was no record of them. So you couldn't attribute a cost to them, and you couldn't code their data because there was no record of list of where those patients were. It was just that the ward would have a list, and the patients would come in, you'd tick them off, and they'd go off. You might get a note written in the notes or a discharge summary, but there was no record of them attending really on the electronic systems. So it's just making sure all that data is captured. Phone calls, another one, a big one. If you've got a phone clinic, but there's no actual list of what's covered, you won't get the data captured. An interesting one that's arising in the next probably year or so will be there's an increase in same-day emergency care. Currently, different people are dealing with emergency care in different ways. So whether it's in maternity, you have your kind of maternity assessment units, you have kind of visit places where you can one-stop visit places, and different organisations are using them as different places, coding them as different things. So some of them they're all being omitted and deemed as admissions. Some places they're being deemed as something else, ward attenders or something else. And in the future they'll come on. They won't be coded in this way by coders, but they'll come under the emergency care data set, which is a different set that A&E uses, ED departments use, which is coded on site at the point of delivery. So that's a bit of an overview of and some of the quirks of coding. Do you guys have any questions or particular comments about coding at the moment before I can waffle on for a bit longer as well, but let's see if we can direct it according to you guys.
And do you have any objectives, like any new data that is missing. And you're going to focus in that data, like, for example, the day-to-day A&E nurses or.
So I mean, A&E is different because they code. They have a system that they kind of do their coding as they go. It's not as detailed because it doesn't tend to be as complex. So you don't have the kind of complexity levels because it's not linked to. There's normally shorter missions with limited interactions. So A&E is part of the emergency care data set, and that's kind of the problem. Is that if you have so some places have clinics where people come and have a quick system assessment and then they get sent home, and in some places that gets as an admission, but there's not enough there. You might only see them for a clinician may only see them for 10 minutes. They might do a blood test. If it's negative, they'll send them home. So for DVT clinics and things like that, for deep vein thrombosis. But depending on how the attendance is classified will determine whether it gets coded fully or just gets which data pool it goes into, the emergency care data set or the main clinical coding set, and there's a difference. Okay, so for A&E, as long as you write things down clearly in the notes, it will be coded appropriately. That's the thing. Okay, so payment-related coding once you're blocked. Yes, it is. It's just more in an indirect way. So you're on the block contracts. You have to kind of have an idea of your historic coding levels. Your activity levels are based on the coding. So if you say you clips X number of aneurysms, or you do this many craniotomies, or whatever it is you do, then that data, that activity data, will be used in the negotiations for your next block contract, your next contract. So negotiations start normally in the kind of about now for next April. And then they get finalized. So you kind of form the activity data. You kind of work on your costing data. So you combine your activity data with your costing data to see how much it costs to provide that stuff. And then that part forms part of your discussions when you're putting it forward to your commissioners. So whether that's specialised commissioning or your commission, or for you, I mean, you're mostly specialised commissioning, I would have thought.
Yeah, sorry, my question was a bit. I understand that, but that's in terms of the amount of activity we're doing in number of cases. But before, we used to have an issue where if we weren't coding properly, like morbidities and etc., we weren't getting paid per patient because it was, we're getting paid per patient. Does it make a difference these days? If you
well, it does, because it's not just activity data, but your complexity data also has an impact on that, because that will impact on your costing. So you kind of have to get your coding right and your costing right, because what you want to know is how much it costs you, because it will cost you different amounts to provide a care for somebody who with lower comorbidities than a higher comorbidity. So your HRG groups, you have an HRG group for somebody with they have CC scores, which are comorbidity scores essentially, and you have 0 to 3, 0 to 3 to 5, or different HRGs have different comorbidity groupings, and that will have an impact on that. So your activity level is influenced by your comorbidities that are coded. Do you see what I mean? Yeah. So and some comorbidities will have a greater impact on certain HRGs than others. So I don't think hypertension doesn't really impact on cardiac comorbidities, because so if you had cardiac surgery, almost everybody's assumed to be hypertensive, so that doesn't have a big impact. But liver disease has got a big impact, so it improves your CC score by a certain amount. And the same applies to mortality. So so your HSMR, which is your hospital standardized mortality ratios, are massively influenced by your comorbidities as well. And there's something called Charlson Index, which has different weightings for your different comorbidities as to how much impact they have on your mortality ratios, and how so that also has an impact. So any other questions at the moment? Oh, okay. So I mean, in the previously, for the kind of radiology aspect of things, Loella, when it was payment by results or national tariff, you had coupled diagnostics and you had uncoupled diagnostics. So some diagnostics are included as part of the HRG. So of the tariff, certain diagnostics are included. So for example, an X-ray, hip X-ray for a hip fracture would be included, but a CT scan for a hip fracture wouldn't be included. And so it's called an uncoupled, so you get extra money for it. But again, you need to build that into your pathway when you're looking at costing. So whether that's for your business cases for increasing demand or for costing and negotiations in the future, you've got to work out what is expected and what was extra in terms of your activity levels, and you can use costing and coding in to look at discrepancies. So look at the model health system, look at your weighted activity units. You can look at mortality, GIRFT reviews, so they're getting it right first time reviews. Often we'll use the coding stuff for that as well.
Sorry, so within radiology we tend to use codes that will relate to the procedure that's been done. But
yeah.
Whenever we have a question around, like for example, if you did a lumbar spine MRI on a patient, that's one thing. But if you did a lumbar spine with a general anesthetic, you still use exactly the same code. So we never quite understood how the coding related to money.
So in that way, it is slightly different because under an anesthetic, that comes as an admission. Because at general anaesthetic, you'd have to have a hospital bed. So whilst a lumbar spine can be done as an outpatient, if you do it under a general anaesthetic, it has to be fully that attendance would be fully coded as an admission, and you'd get a general anaesthetic has got a code to it.
Okay, all right.
It doesn't necessarily match to a tariff, but there is a code for general anaesthetic.
Okay, all right. So I can understand that, but then possibly someone who arrived just for intravenous sedation. There's just no way of I just find that the codes sometimes that we use in radiology are very generic. There doesn't seem to be a lot of levels to them.
No, I think particularly with radiology, but so it depends on how your sedation is classed. So I would have thought that anything requiring sedation would need to be as some sort of ward attendant. You can't have it as an outpatient. Essentially, you have to have it as, even if it's a short admission, it would be some sort of, because you have to have a recovery space. You have to have a recovery area, don't you? So you would have to that would have to be on a list and be coded in some way, not by yourselves as the radiographers or radiologists, but it would be coded in a different way because of the fact that they have had sedation.
Okay.
So it's not, so it depends on how your organisation has classed that attendance, whether it's admission, whether it's a day case, whether it's and whether that gets coded properly. Because of that.
Okay, I get that. So in actual fact, in my trust, we're probably missing a trick because we don't actually admit those patients. They just come in as an outpatient, and then they'd be sort of monitored after their procedure by our nurses. But they haven't actually been attended as something different. So we probably are missing.
You probably are, yeah. I mean, it's probably just how you're classing them. Whether you're classing them as an outpatient, in which case you probably are missing a trick. Or you're doing it as a ward attendant or a day case, because sedation is is an extra cost, and you need monitoring and all that other stuff.
Yeah. No, okay, thank you. That's very helpful. Thank you.
Okay. Any other questions? I know, Grant, so in terms of community stuff, the coding will probably not directly impact you, I don't think, as if you're working mainly in the community, but it might have an impact on if you're trying to come up with a pathway and working out activity data to help maybe justify your particular initiatives that you're doing.
Mm-hmm. Yeah, as you said, so we're a mental health trust, so we do clustering and sort of HONOS, and it's always, I don't know, I've never been too up to date with like how it all works or why it all works, but it's always boggled my mind a little bit that the whole, I think in other areas of mental health, it's about reducing somebody's HONOS score to show improvement over time, but with my patients in particular, their HONOS score will generally increase over time as their cognitive decline and physical decline happens, and it's kind of like, yeah, we're almost charting somebody, not getting worse, but you know what I mean, like we're having inputs but not showing.
But I think the idea behind the introducing of clustering and HONOS was not necessarily to try and use it as a target to decrease, but actually it's more about the amount of resource it's going to take. So as people get older, or as their condition deteriorates, that will require more resource. So I think it's not that the score is there for a particular reason. I think it's how we're using it. So in certain areas of mental health, it will be a good idea to use HONOS as a showing progression, but in kind of dementia and in cognitive decline situations, it's more of an idea that actually if your proportion of patients are increasing their HONOS scores, then actually they need more resource. They're going to cost more to provide care for. And to be honest, costing in mental health is very much in its early days. It's in its infancy, and it's still being molded and adapted to work out how it would all fit together. The kind of tariff system for mental health never really got off the ground. That's why it was introduced, to try and get more data, because it was really hard to measure the activity levels that in mental health and community. So they started by trying to get at least data by using clustering and HONOS scores, but then block contracts continued for a lot longer than they was intended. So it's how you use it. So use your HONOS scores to justify increased resource is probably the best way of doing it, rather than because they are more intensive patients.
Yeah, absolutely. Yeah.
But I guess it's because you automatically do HONOS and clustering, coding is much easier. How accurate is a different matter, but
oh yeah, that's the thing. You sort of go and see patients and come back and go to cluster them or do the HONOS and see the last episode of care that they weren't too different, but they were clustered or scored incredibly differently just based on the bias of the other scorer.
Unfortunately, that's probably one area that's really subjective. HONOS and clustering is very subjective, and I think that it probably will be improved at some point, but we'll see.
Yeah. Cool. Thank you.
Anybody else have anything? So other issue. I mean, general practice doesn't use coding in the same way, and other things to be aware of. And I'll if this works, I'll show you some of the things. So HSMR is based on your comorbidities that are documented in the first first consultant episode. So if you have a patient that changes consultants, so whether in an acute setting, and they change consultants because you have different consultants during the day, that can change their HSMR dramatically because their comorbidities may not be included. Other things do we can cover? So therapies, I've said. R codes. So R codes are signs and symptoms. So codes where you haven't got a diagnosis, though they've just gone for, abdominal pain or chest pain or headache, which are not very accurate, not very good. It's thought of as poor coding practice if you've got a high proportion of R codes in your systems. So you ideally have some sort of headache, whether it's a non-specific headache, is probably not an R code. But you try and get some idea of what your the better accurate, the more accurate it is, the better it is, and the more funding that's associated with it, essentially. So things like, the difference between cemented and uncemented hip replacement is actually quite big. So it's just worth knowing that there are kind of intricacies and within the coding system. But as I said, coding is not as hasn't got the same momentum as it had previously because of the change in the payment systems. But it is still pretty important. Any other questions or comments? Is there anything that you want me to go over again or want to go in more detail at all? So coding doesn't really work. Coding is completely different in primary care because it's not done by coders as such, and it's done. You kind of do it in your system. It's codes. The GPs code themselves, and you'll kind of, whether it's whatever system you use, system 1 or another system, you code as you go along, type thing. When you write your diagnosis in, and it has a different type of coding, because you need to make sure you hit your quality outcomes framework points. There's little points you get for doing it. So it's actually much, I wouldn't say it's better done, but it's done more consistently, because the GPs have to do it themselves, or the kind of clinicians have to do it themselves at the time of data entry. Is coding team and quality team related? Not. Do we work? Do it? Depends on the system. Depends on your. So, for example, in my trust, I'm the kind of clinical coding lead, but also the costing lead. So yes, I make sure we work together, and I make sure it links together, the costing side of things and the coding side of things. And I'm a clinician, so there is that kind of triangle between us. Data quality. Yeah, we have coding and data, business intelligence. We have a business intelligence person that works specifically on coding, that looks at and feeds into mortality data, looks for any quirks in the mortality data. But we look at depth of quality, depth of coding analysis in that way. But it will vary between different organizations.
Sorry, following up the question.
Yeah.
So you say that you are the link between the coding and the costing. Can you explain that better? How do you?
So I'm the clinical lead for coding in the trust, but I'm also one of the leads for costing in the trust. So most of the time, I look at the most common way that we kind of link it together is looking at costing, looking at quirks and errors in the costing, and it's normally due to a coding error. Now, it's not normally the coder's fault. It's normally some sort of documentation or process issue, but it's looking at that you use your costing as a way of finding out errors in coding. It's not in a big consistent errors in coding and pathway issues. So that's what we've done. So we looked at, for example, or Leeds have done a lot of work on that, and they've done things like looking at the cardology process, looking at their why were some the average time it takes to deliver a normal PCI, so stenting, takes 45 minutes. Why were these other patients taking an hour and a half? Is it because of something, it's just a quirk in the system, or were they doing a much more complex procedure that wasn't being coded properly? And most of the time is actually they were doing lots more complex stuff and there were bits missing off the coding. Okay. So you're using your costing to look at your coding data, to look at identify issues in your coding, and that's where things are missed out. So if you have a proportion of patients where you're kind of going, okay, why is this one costing a lot more than this one? Is it a process issue or is it a coding issue? Okay, so I mean we've done some stuff where one of our problems is that how our theatre lists have been organised means that some of our local anaesthetic patients cost a lot more than they should do because anaesthetist has been allocated to a local anaesthetic list, which means that will drive the cost of that local anaesthetic up because there's no, we don't need to be there, but that's more than the average. So some of it's a process issue and scheduling issue, but some of it is a coding issue. If it's a more complex, is it the fact that the sedation bit has been missed off the coding? Is it that it wasn't really, is a block rather than a regional block rather than a local anaesthetic, which again changes the kind of coding.
Do all the trusts work like that, or is your specific trust?
Different trusts do it to different extents. So okay. I think there will be an increasing amount of doing that, but so some trusts do it a lot more. So Leeds do it a lot more. We do it a little bit. We're just still in the early stages of doing that kind of analysis. I don't know about how LTHTR does, but yeah, different places will do it to different degrees, depending on how advanced that kind of collaboration between the clinical side and the coding and costing side is.
Okay, thank you.
Okay. Any other questions? I've covered everything I need to cover in a way, or I was planning on covering. But the point of these workshops is to make it a bit more specific and interactive. No, hopefully you found it useful and made some sense. I said there are some quirks to it, but most of it is just making sure we document things appropriately and getting the coders to know where to find the stuff that they need to find.
I have another question.
Yeah.
Does the coding affect Plix? Because that's what I work in mainly.
Yeah. So coding feeds into Plix because your Plix data is based on the coded data. So your activity data is from the coding systems. So that's what feeds into your Plix systems. So yeah, it directly impacts that, and how you determine your costs will be determined by, that's how you look for patterns in your costs, by looking at your Plix. I said I'm happy to. So because I'm happy to answer specific questions. You can email me or you can email FFF, and they'll forward it on to me. Any more detailed questions, so that we can link you up. We can either link you up myself, or we can link you up some guys in the Leeds who do some Plix and coding, and show you how they've done their work. Leeds are quite an interesting trust because they've got the scan for safety stuff where everything's barcoded, which means that they have their level of accuracy and their depth of coding is much better because they know everything just because of the barcoding systems they use. No. Okay. Well, good. I said I hope you found it useful. The animation's available on YouTube. You just put clinical coding NHS, it comes up. So if you want to watch it again or you want to go over it again. Okay, well, thank you for coming.
Thank you very much. That was great. Thank you.
Thank you so much.
I know some of you are maybe coming to business cases, and I'll see you there if you are. But otherwise, I'll speak to you later. Good luck. Take care.
Bye.
Bye-bye.
Bye.